Today we have a very informative session entitled Scalability, How to Take Your Telehealth Program to the Next Level. Certainly a topic that is of importance and at the top of mind when it comes to all the discussions we have about digital health and expanding the use of telehealth. Our speaker today is Director Saleem Sayani, and he has some wonderful information regarding how to start a program and successfully scale it. I will first like to give you a tad bit of information about the society that is sponsoring the program today. The International Society of Telemedicine and eHealth. I will be sharing, so I can just give you some information. And certainly if you are interested in joining, I will give you that information as well. Let me just share my screen. You should be able to see 1 second. Oh, here we are. Excuse me one. Here we are. All right. So I'm going to share that. I'm going to go from the beginning. So the International Society of Telemedicine and eHealth is a global digital health network. There are over 100 countries that are currently members representing the organization. We have national telemedicine associations, eHealth associations, healthcare providers, policymakers, industry representatives, researchers, and educators. It is a wonderful organization that's been in existence for over 25 years. It is an official partner, non-governmental organization partnering with the World Health Organization. Very prominent when it comes to networking and creating connections, alliances, collaboration, whether it is in the digital health development realm, or dealing with policy and implementation, research and education. The global network is well known for sharing knowledge, experience, and expertise. So also new services that we have coming up, professional certification, accreditation of telehealth services, and assistance with regulations and registration. So if you are interested, the network is been around a long time. It continues to grow. We have a national, international, I should say, conference annually that is well attended and has been a major resource for education and networking. And this is information if you're interested in joining. Please go to our website. I will also put this in the chat so that you have all the information that you need. So at this time, I am going to introduce our speaker today. Director Saleem Sayani is a digital health transformation leader with over 30 years of international experience in delivering innovative technology solutions that drive change and business success. He has played an instrumental role at various organizations in implementing technology solutions that foster innovation and promote quality healthcare provisions to underserved and vulnerable populations. As director of AKDN, he spearheads and manages digital health systems and a portfolio of innovative digital health projects, programs, and solutions. He provides leadership, strategic direction, and guidance across AKDN entities to deliver healthcare services and learning programs in South Central Asia, Africa, and the Middle East. Mr. Sayani, I give the webinar over to you.
Thank you, Michelle. And good afternoon and good evening, everyone, depending where you are. So, Michelle, thank you for inviting me to this webinar, and I'm very excited to share the learnings that we have over a period of time when it comes to digital health and telehealth program. So I'll share my screen and we'll go through a presentation, and then at the end we will have question and answer. So I'll be happy to answer any question that you may have. So let me share my screen. Great. So today's talk is about telehealth and then how we can scale our program to the next level. So in order for us to scale, we need to make sure that we have a sustainable program. So we'll talk about that. And then let me just walk you through the roadmap of this presentation. So we'll talk about AKDN digital health program, and I'll share my experiences with you that how we established this program in Pakistan, Afghanistan, Tajikistan, Kyrgyz Republic in Asia, and Kenya, Tanzania, and in Africa, Eastern Africa, and also in Middle East, in Syria. Then we'll focus on SDG and then our aim, what we're trying to achieve towards 2030 goals when it comes to SDGs. And then we'll talk about digital health network that we have. I'll give you a brief tour of Asia and Africa. And then something that is really important, we'll talk about evidence. What evidence that we are providing in terms of proving the efficacy of telehealth, telemedicine, and digital health. And then I'll use an example that is of Hayat, that is an application. And then what are the challenges that we face? What were the challenges that Hayat intervention is trying to address? What is the solution? What worked? What did not work? And then we'll talk about sustainability models and then how we can scale and sustain these type of networks and these type of programs. And then I'll briefly give you an overview of innovations, because I believe that telehealth program or digital health program is not just one area or one vertical. It is a combination of different interventions. So I'll talk about some innovations in digital space and then some mobile application. So let's get started. So as you know that areas where we work, the Aga Khan Development Network where we work in hard to reach areas. I'm not sure how many of you have been to countries such as Pakistan, Afghanistan, Tajikistan, Kyrgyz Republic, especially because we have very isolated communities in these countries, and most vulnerable population lives in these countries, some of these countries, and in the mountainous regions. So there's lack of healthcare institution, quality healthcare institution. There is a dearth of health specialists. Whenever we have healthcare staff, they are so isolated, and patients always feel that they face a challenge of traveling, long distance travel to get care. So sometimes they may not be able to actually travel because they don't have means to travel, right? So that results in poor health outcomes and poor quality of life. So digital health, in my opinion, actually addresses all these challenges, and it provides healthcare where it is needed, when it is needed. So within AKDN network, digital health network, what we try to do, we try to address these 6 SDGs, Sustainable Development Goals. So I'm sure you all know, SDG 3 is about healthcare for all and well-being. This is what we do through a telemedicine program. Quality education, which is SDG 4. We do this through e-learning program, which is part of digital health program. Then we also focus on gender equality throughout our programming. So that is a cross-cutting theme. And then we need to understand why it is important, and I'll talk about that. SDG 9 is industry innovation and infrastructure. So that is telemedicine is all about when we talk about innovation. And then you'll see how. We also focus on SDG 10, that is reducing inequalities, so that we make sure that we provide access to healthcare services to those who don't have access to healthcare services using technology. And then also creating partnerships. And this forum is a very good example of creating partnerships, because this is where we get together, we share our ideas, and then we see how we can work together. So where we work in South and Central Asia, as I said, we work in Pakistan, Afghanistan, Tajikistan, and Kyrgyz Republic. And in East Africa, we work in Kenya and Tanzania. So these are countries where we operate in terms of digital health network within our AKDN Outcome Development Network. Now, this is just to give you an idea about the density of a digital health network that we have in Asia, South and Central Asia. So you see at the bottom right, you will see Pakistan. That is our super hub. We follow a strategy that is spoke and hub model, we call it. And a hub is a site that provides services. Spoke is a site that receives services. So in Pakistan, we have so many one main super hub, and then we have so many regional hubs, and then spoke sites. And these sites are connected to Afghanistan. As you can see these sites are also connected to Tajikistan, a cross-border area between Afghanistan and Tajikistan, where people have low resources, but they still get sick. They still need some healthcare services. So we found that digital health is the excellent tool to provide them services they need with the resources that they have. If you look at the top right, that is Kyrgyz Republic. And then you see that Kyrgyz Republic, we have about more than 15 sites there. And something that is very interesting here is that you should know is that it is not just AKDN network that we are connecting to. It is a true sense public-private partnership. So we connect our entities, AKDN entities, within AKDN entities, and we connect AKDN entities to government facilities as well. So we provide expertise where government does not have expertise. We provide that facility and then expertise to provide teleconsultation. And in Kyrgyz Republic case, we actually built this network, telemedicine network, and Kyrgyz Republic government took over and they are managing it right now. So that is a prime example of how you can have a program, and if you can show results, then government is actually willing, Department of Health and Ministries of Health, they're willing to take over the operations of it. And then we'll talk more about that in a minute. And this is just to give you an idea about our network in East Africa. So you see Kenya, Tanzania, and in Uganda. So we have all these hub and spoke network, digital health network. We provide telemedicine, teleconsultation. There's also e-learning component that we provide. So, you know, one of the challenges that we had is when we depute healthcare workers, be that a nurse or a doctor in a remote area of these countries, they go there with very much enthusiasm, and they're very enthusiastic when they go there, but then reality hits and they feel so isolated. And we face retention problem and in these countries. So what we started doing, we started connecting them through e-learning sessions so that they feel that they are professionally connected to their group. And then we saw that we could retain more healthcare workers in these regions. So that is one example. And then we provide them long distance learning through a network in US, which is IHPA, Ismaili Health Professional Association. They conduct training for nurses and doctors and researchers. So that is a good connectivity tool that we use when it comes to e-learning. Now, let's talk about evidence. So everything I said, it sounds very good, right? And it's a good story, but what does it mean? What is the evidence that it actually works? So this is the evidence that I am sharing here with you. This is a research paper that we published in 2020 last year. And this was data from 4 countries, Afghanistan, Tajikistan, Pakistan, and Kyrgyz Republic. And you can see that the sample size was more than 25,000. And what it shows is that with just $2 million investment in these 4 countries in telehealth program, we were able to save $9.1 million just to beneficiaries in cost avoidance. And in terms of time saved, it was 213 years worth of a time that was saved. And this is a peer-reviewed paper, so you can rest assured that this went through the entire vetting process. And these are numbers that you can take and you can advocate telemedicine program and its efficacy and its effectiveness globally wherever you go. If it can work in Afghanistan, if it can work in Tajikistan, Pakistan, and Kyrgyz Republic, it can work anywhere. Now, let me give you an example of a program that is, we call it Hayat. Hayat is a telemedicine mobile application, and it is community-based data collection tool. So the challenge was that we, in Pakistan and Afghanistan, we saw that there was very low maternal and newborn and child health outcome. So numbers were very low. When it came to vaccination, numbers were low. When it came to IMR and MMR, numbers were very high. And then there was no tracking, and there was no proper governance of healthcare workers. And then there was no transparency, actually. And Department of Health came to us and said, well, look, we have this problem, how technology can help solve this problem. So what we came up with was a solution that is a mobile application, which is Android-based application and a web portal. So this Android application, what does it do is it collects information, it empowers frontline health workers, actually, be it lady health worker or the vaccinator, so that we digitize the entire spectrum of MNCH care through Hayat application. So now you have this mobile application, which is HL7 compliant, so that we made sure that application that we develop, it adheres by the standards that WHO has mandated. And then the web portal, that is a centralized database server. It connects different programs. So Lady Health Worker program connects with EPI program, and then we share single database so that it reduces the redundancy that we see. And the good thing is that data is available in real time. So if you're a healthcare administrator, what you can do is that you can see, if you have internet connectivity, you can see where your health workers are and what are they doing, what is their performance, and what is their workload. And then you can plan your resources accordingly. Now, one of the challenges that we faced was that in the countries, as I showed you earlier, Pakistan and Afghanistan, connectivity is a huge challenge. So initially we thought, well, we will have connectivity. Then we learned through the process of stakeholder engagement that that was not the case. So we made sure that this application, actually Android-based application, works in an offline mode. So whenever connection is available, then you can upload this information. So it is very similar to you going to Starbucks or Dunkin' Donut and then syncing your data, right? Now, these are the countries where we implemented this Hayat application. So in Pakistan, there were 49 healthcare facilities. In northern Pakistan and in Afghanistan, These were 7 healthcare facilities, and we are moving forward, and we are actually expanding now to Gilgit, Hunza, and Nagar. So we are adding 3 more districts, in fact, Astor as well, so 4 more districts in Pakistan based on the success of the program. And in Afghanistan, we are adding some more sites to it as well. Something very important, and we'll talk about this in sustainability, is that proving your intervention that it works is critical. It's critical for our scalability, and also it is critical for our sustainability. And I'll talk about that. I'll come back to it. So this is to give you an idea about how this application looks. And then you will see that this may look very foreign to you, but this is local language. So one of the challenges that we heard in the field when we went to Afghanistan and Pakistan in northern areas, we found that whenever we talk about a mobile application, usually we think of a mobile application in English. So that doesn't work in this part of the world. So we made sure that we don't have this roadblock for this application. So we made sure that this application was in local language in Pakistan, which was in Urdu, and in Afghanistan, it was in Dari, that is local language there that people can read and understand. So the slide that you see here, this is in Dari, and these are different screenshots of this application that you will see if you go to Afghanistan or if you use this application. Now, something interesting happened. So when we implemented this project, there was no integration between EPI program, which is Expanded Program on Immunization, and Lady Health Worker program. So we found out during our consultation that there are 2 ways that we can actually have integration. One is that you have common human resource to perform certain tasks. If you do that, then you can have integration because the same person is performing EPI function as well as Lady Health Worker program functions. But that was not the case here, right? In both countries. So what we decided to do, we decided to make sure that we provide them with a platform that forces them to actually work together and without having any resistance. So now what is happening is that Lady Health Worker, she goes in the field, in the village, and she finds out, she's the first one to find out that there's a new birth in a village. So she registers that child, and then through the application, vaccinator knows that, well, there's a new child and he needs to go and vaccinate that child. So now there's a seamless integration between these 2 programs, which has increased the coverage in the program area, which is fantastic. Now, the whole idea was that why do we implement digital health, right? Why do we do what we do? The only goal that we have in all these countries where we operate is to strengthen health system so that health system can be resilient, health system can be effective. So you see here, we talk about 7 factors. So we wanted to make sure that there's an integration between different programs. And I just showed you an example of integration between 2 different verticals, EPI and Lady Health Worker program, and also close to real-time monitoring. That is very important. If you're a healthcare administrator, then you need to see the data, what data you have available that is coming from the field. You don't have to get data after 2 months of it actually happening, right? So we wanted to make sure that there's a close to real-time data that is available for data monitoring so that you as a healthcare professional can make sound decision, timely decision with the data that you have available to yourself. Also creating demand for the services, that was very important. Uptake of services, because as you digitize program, then you standardize program. Once program is standardized, then you see that there's a increase in demand, also increase in coverage as well. So what really worked for us? Very important question. So we found that nothing works in silo. We need to work very closely with all our stakeholders. We need to engage all our stakeholders, and these stakeholders are our beneficiaries. These stakeholders are our EPI and Lady Health Worker Program directors, program coordinators, secretaries of health, and in these countries, and also the donors who are funding these projects, right? So stakeholder engagement, we feel, is very important. And then we wanted to make sure that we create something. And this is my advice to you: if you're looking to create an intervention, then you got to talk to people who are going to use it, because you need to get their input first, because you don't want to create something that they will not be able to use it, right? Or they have hesitation in using. So we had focus groups, and then we did human-centered design approach, so that we can make sure that we get input from our end users who are actually our ultimate beneficiaries. We also made sure that there was capacity building. So technical capacity, we wanted to make sure that it is not dependent on our experts. So we develop government capacity. That is very important. So that is one way for them to sustain it long term. And we've always made sure that end goal, we stay focused on that. And in our case, end goal was there were certain indicators that we wanted to increase the uptake. We wanted to make sure that all women, pregnant women, they get more than 4 ANC visits, so that there's healthy outcome to that pregnancy. We also wanted to make sure that our system is so nimble that we can adapt it to any situations, because, you know, I'm sure we all know we could have never planned for COVID-19, right? But it happened. And since it happened, we wanted to make sure that we can adapt to that context of COVID-19. And we did that, and we used this tool to actually increase our interaction with communities remotely, rather than having physical interaction with them. So it worked very well. Now, so as I said earlier, that digital health or telehealth program is not just teleconsultation, it is beyond teleconsultation. Teleconsultation is one part. So we also want to focus on innovations. We also want to focus on biomedical innovation, which is low cost, which can be affordable to these geographies where we work. So I'll briefly go over this. On the top, on the left, you see surgical tray. That is a smart surgical tray, and it is designed. It uses augmented reality markers and an algorithm, smart algorithm, to make sure that you as a surgeon, you don't close a patient until system tells you it is okay for you to close that patient, and it makes sure that you have not left anything inside patient. It poses patient safety risk as well as litigation risk to the health system. So there is a patent for it, which Aga Khan University has received in the US, and we are about to commercialize that. In the center top, you see a multi-purpose scope. So we decided to use mobile phone. Android mobile phone are very common nowadays, and we developed 3 endpoints so that one mobile phone can work as otoscope. It can also work as a dermoscope. It can also work as an ophthalmoscope. So just imagine each scope, if you want to go and buy it in the market, it'll cost you, each scope will cost you around somewhere between $1,000 to $1,500. And the total cost of this solution is less than $1,000. So this is something that can be used in low resource setting, and that is the intent. On the right top, you see a ventilator. This is a low cost briefcase size ventilator that we developed and we got patent for. And this is for those people who need regulated oxygen while they are on the way to hospital, for example. So there was recently an incident where a doctor was in an ambulance and he needed a ventilator, and he could not get to a hospital in time to get a ventilator, and he passed away. within the ambulance. That is something that should never happen to anyone. And if we had this ventilator in that ambulance, then we could have provided regulated oxygen flow to that patient for at least 6 hours. So that is just to give an idea that what is possible. Also, you see in the middle bottom, there is a swab. So this is a nasal swab that we actually printed. This is 3D printed nasal swab, printed by a 3D printer at AKU, at Aga Khan University. The challenge was that during peak time of COVID, there was a break in supply chain, and then we could not get essential supplies to test patients for COVID. So we decided to actually develop this design and print it. And now we are using it in one of our labs in AKUH, Aga Khan University Hospital, Karachi. The good thing is now we don't have any dependency on third party, and the cost is very low. So this is just to give you some idea about the innovations that we have and we can think about. These are some fantastic mobile applications. I talked about Hayat. There is Ilaj Asan and Pigya Daktari. So during COVID time period, there were people, they were avoiding coming to hospital, but that did not mean that they were not getting sick. They did not did not need medical advice. So Pigya Daktari and in Swahili means call a doctor or hello doctor. So that is an application with which you can sit at home comfortably and register yourself, your family members, and then you can actually schedule an appointment on this application. You can make a payment using M-Pesa, for example, and then you can actually have a virtual consultation. And after consultation, your physician can prescribe you either lab tests or medication, and your medication can be delivered to you at your home. So you don't have to actually leave your home. So that has been implemented in Tanzania, also in Pakistan. We are working to implement this in Kenya right now, in Nairobi, Kisumu, and Mombasa. So that is an example of a mobile application which is digital health related. And then a Corona check. So, you know, this is interesting that it uses an algorithm and it is a self-screening tool for Corona. So you don't, if you feel that you have COVID-19, you can just answer a few simple questions, and then it tells you whether you need to go and see a doctor or you need to get yourself tested, or no, this is a false alarm. You don't need to do anything. You just need to take precautions. Now, interesting thing here is that in this application, again, usually the country that we work in or the countries that we work in, the literacy level is low in these countries. So we wanted to make sure that people at all levels of all walks of life, they can use this application. So we made sure that this application was in English as well as in local language. So for Pakistan, it was in Urdu as well. But we also then thought that what if people cannot read local language? So we made sure that there was an audio for each question. So there's an audio feature for each question in local language. So you can respond, you can hear the question, and then you could respond in local language, and then you can benefit from this application as well. So this application is in 5 countries. It is in Pakistan, Afghanistan, Tajikistan, Kenya, Tanzania, and Mozambique. Now, scalability. So this is all good to have all this digital health program and all these interventions. How can we scale up, right? And then what are few elements that we need to be very careful about and we need to think about? So in my opinion, I think there are 6 factors that we need to consider when we think about scaling up telehealth program or digital health program. One is opportunity. We need to see if there is an opportunity. If there's no opportunity, there's no point in scaling anything, right? The future growth, you need to see what is the level of future growth, or what is the potential of future growth in that particular geography that you want to scale up, and does it make sense? So that is very important. Now, third factor is competition. Do you have a competition? Is there a competition in the field or in the geography where you are trying to scale this up? Sometimes competition is good, sometimes competition is not good. So you need to see what is that context, right? And then what is your competitive advantage if you have. Then most important factor is that do you have investment available? Because if you don't have investment available to scale up, probably 99% of the cases, you will not be able to scale up, right? So that is very important. And if you do have investment available, what type of investment that is that you have available? Is it a grant? Is it a loan? Is it a impact investment? So you need to think through that. And then something that is very important is your team ready on the ground? So you may have investment available. You may have, that you do or do not have competition. You may know that there's a future growth. You may know that there is an opportunity. But if your team is not ready on the ground, there's no point that you need to scale up. You cannot scale up, because if you do, you're setting yourself for failure. Now, also, you need to see product market fit. So whatever you're trying to sell or whatever you're trying to have implemented, does it fit in that market? That is very important. And I give an example. If you come up with a mobile application, and that is iOS-based Apple application, and you come to me in Pakistan and you say, okay, I want to implement this application. This is fantastic application. I want to implement this in northern areas of Pakistan where people don't have Android phones, then it won't work, right? So I think we need to see if we have market fit. That is very important. Now, this is the formula. This is the formula to success. And it has worked for me very well, and I hope that this will work for you. So if you have two geographies, for example, that you're thinking to scale and you don't know, and you have funding for only one, so you need to pick one. So how do you do that in a way that makes more sense, right? So you see all these 6 factors that we just talked about. You put on an Excel spreadsheet, and there's a weightage to this, which is recommended. So opportunity is 20%, future growth is 10%, competition is 15%, and investment, as I said earlier, that is very important, and that is 25%. Team readiness is 20%, and product market fit is 10%. So you evaluate that, and it may vary. You may want to change weightage to some of these based on your environment. But generally speaking, this will give you a very good idea if you use this tool to make a very objective decision on where to scale, and if you need to scale, and if you have 2 options, which one has better chances of success. And as a disclaimer, this tool was developed by WeScale Impact in partnership with Grand Challenges Canada, that has funded the project that we just talked about, that was Hayat project. Let me see. Okay, now, so if we can scale up, then that is good, but how that we can sustain it? That is the question, right? So scaling is not enough. You can scale up and then you can still fail if you cannot sustain it. So idea is how to sustain the program that you have scaled up. There are 3 models there that I'll talk about, and there are many more, but I'll focus on 3. So, and then model number 1, government takes care of all expenses. And a good example would be that where government is responsible for providing primary care, right? Or secondary care or tertiary care. So in US, Medicare is a good example. In Kyrgyz Republic or in Afghanistan, interestingly, basic health coverage is responsibility of the government, right? So government has this mandate to provide this service to its population. So that is one. Second is when government works with donor agencies to see if donor agencies can invest part of it and then government can sustain it and then scale it up and sustain it long term. So usually what happens is donor agencies such as USAID, Global Fund, Gates Foundation, and then all other Grand Challenges Canada, Canadian government. So all these donor agencies, they come in, they invest, and they prove that something works, and then government takes over. This is exactly what happened in Hayat. So we proved that it works, this application works, and it enhances access to healthcare services. And that is why government in Gilgit-Baltistan, they took over that program. And the third area is where there's a combination. It's a combination of government and for-profit entities. So companies like telecom companies, pharmaceutical companies, and other companies who are for-profit, they partner with government as part of their corporate social responsibility, and they sustain the program. So these are three models, and then sometimes there's a variation to this, where we have government, we have for-profit entities, and then we have beneficiary, who's actually the patient who pays part of it as a copay. So that is also a model that can be used for sustainability. But I think the key is you need to see what works for you and what fits your environment and your context, because that is very important. And it could be a mix and match of all those three. It does not need to be one or other. So with that, I know I took more time than I was allotted, Michele, but I hope that this was beneficial, and I'll just stop here. Thank you.
Thank you so much. I will say that your presentation was filled with so much information, and really the information that is critical and oftentimes sought by people who are interested in expanding telemedicine or initiating telemedicine programs in their respective countries. So of course, your presentation has generated quite a number of questions. So I want to give some time to address and hopefully allow you to address some of those questions, okay? I've got different locations here. First question, curious about the time and cost savings of telehealth teleconsultations. Are teleconsultations conducted from the comfort of the patient's homes, or do the patients have to travel to a health facility? I recently had an experience of teleconsultation with my son, who needed to see a nephrologist, but each time we visit the hospital, the doctor does teleconsultation, but we end up paying the same doctor's fees that we would have paid if she saw my son physically.
Yeah, very good question. So a couple of things. So the study that I presented, that was a patient going to a primary healthcare setting and getting a consultation, a video consultation with a doctor who was not physically present at that location, and whether he was or she was at the secondary care location or the tertiary care location. So depending on the specialty sought, it dictated where to connect. So that is just so that I wanted to make clear that numbers that I shared, that was based on patient going to a primary care setting to seek consultation from secondary care or tertiary care. Now, coming back to the second part of the question, it is a perception, and I always say it is a wrong perception, is that the teleconsultation cost should be same as the cost of in-person consultation. So there are two ways to look at it. One is that since you as a patient are saving money, you don't have to travel, you don't have to commute, and you can get consultation from luxury of your home. You should pay a premium charge for that service. That is one school of thought. Second school of thought is that, hey, hospital, you don't have to use a lot of resources that you will use when you see patient in person. For example, parking, security, housekeeping, and all that. So you need to reduce cost. That is also true. So it all depends how you brand as a health system, how you brand your services, and people do both ways.
Thank you. We have another question. If the target is poor people, how do people pay? The ability to pay through digital platforms in Jamaica is low. Many poor people live on cash because they are unbankable, so that would be difficult.
So I love challenges, as you can see. So this is the challenge that we face actually in northern Pakistan. So because as you all can see, when it comes to digital money, sub-Saharan Africa has made a lot of progress as compared to Asia or Latin America. So we face the same problem. And what we did is that solution was that why don't you, if I am a patient, I go to a facility where a local facility which is close by, which may not have the consultant that I want to see, but there is a branch in my village. I go and I make a payment there, and then I can set up this call, and then I can have this consultation. So I don't have to travel to another village, for example, to see a consultant. I can go to my primary care setting in my own village. I can make payment, and then I can get teleconsultations. So that is one way. That is not the ideal way of doing it, but that is one way in absence of the infrastructure of e-money or e-commerce. That is something that we have done.
Thank you. We have, so I think you've already answered this question. Actually, what are the prerequisites for successful scale up of digital health projects? You answer that through your presentation. Also, what challenges do digital health projects in low and middle income countries face that hinder their scale up? And I think you've covered that as well. Is there anything else you want to add?
Yeah, so I think, the challenges that digital health programs, they face, these are not unique. I think these are more challenges on people challenges rather than technology challenges, because there are a couple of things. One is that we as technologists, sometimes we feel that we have a great technology and it can solve all these problems. So we focus so much on technology that we forget to focus on problem that it is trying to solve. So and that is something that we need to be very careful about. We need to identify a problem first, and then look for a solution rather than having a solution and looking for problem to solve. So that is important. And also, I think what is very important is that stakeholder engagement. So your digital health project will be successful or it will fail based on how you manage your stakeholders. And when I say stakeholders, I mean every stakeholder, your beneficiaries, your donors, and your health system experts within that geography. That is very important because they are going to actually sustain your program once you get out of it. So you want to make sure that they are on board, they own the program, and there's only one way that they can own the program is that they are involved in this program from day one and they have ownership of this program. So that is very important. So I say quite often that let's do the work and give credit to people who are going to sustain it.
Great. Next question. It is easier to connect a doctor through teleconsultation, but how to make sure to make diagnostic tests and medicines available after teleconsultation at those remote locations?
Very good question. So, fortunately, within Aga Khan Development Network, we have a network where we have primary care settings, we have secondary care settings, and we have tertiary care settings, right? So at all levels, in geographies where we work, we do have diagnostic tests available. We have pharmacies where we can get medications from. So that is fortunate. That is not, it doesn't happen everywhere. So it could be a challenge, but what we do within this application is that we connect patient, doctor to nearest pharmacies and nearest labs and then radiology services. Most of the time, this is within our health system, but if it is not within our health system, we can connect it to the nearest based on the Google map, where we can take 5-mile radius and we can say, well, these are 5 pharmacies available, and you as a patient choose which pharmacy you want your medications to be delivered from, and likewise for lab tests and diagnostic tests.
Okay, thank you. Next question. Scalability is, excuse me one second, this is blocking my view. All right, let's, here we are. Scalability is very fine, but it would be very difficult even applying the 6 points you enumerated. We lack power supply, broadband internet access, and have very poor communities. And this is from Dr. Magnus Chinamaram Ogaraku from Nigeria.
Yeah, no, and I can completely relate to that because I work in geographies very similar to Nigeria, where we have power problem. There's no power for 12 hours out of 24 in a day. So there's a high dependency on solar power, right? So and in Afghanistan, for example, in some of our facilities, we have solar panels, and then we power our telemedicine equipment and then everything else that goes in that building through solar power. So life is not ideal, and you will never have everything that you want. But I think what we can do is that we can make most out of the things that we have, resources that we have, and giving you these 6 factors. This was just sort of a guiding 6 factors. If you don't have access to one, then you take it out, and then you do your math. I think idea is that sometimes we just use, and I'm not saying you do that. What I'm saying is that generally what we do is that we don't start something because we feel that we don't have enough resources. My humble submission would be that please start and see how you can make progress. Because when I started this program, it was very nimble program, and now it has grown into one of the largest telemedicine network in the world. So my humble submission is start, and if you need some help, please reach out to me, reach out to Michele. We'll be happy to assist.
Wonderful, thank you. This question is from Dr. Naveed Ahmed. Very informative presentation, Mr. Sayani. My question, data security and patient confidentiality are extremely important. How you are managing security of data and information? Is HIPAA, does HIPAA work for countries like countries like Pakistan?
So it is not mandated, but we practice HIPAA compliance. So even though it is not mandated, but you'll be amazed to know that countries such as Kenya and Tanzania, they are so far ahead in terms of Data Protection Act. And just to give an example, if you have to implement a program in Kenya or in Tanzania or any other East African countries, they will not allow you to host anything. Either it is a system, either it is a data or anything out of that country. So, and then you have to make sure that you are in compliance with their local laws, as well as encryption and all that. So HL7 compliance, HIPAA compliance, these are at times certain variations of that are required in these countries. So yeah, so in Pakistan, in Afghanistan, in Tajikistan, wherever we have operation, we make sure that we comply to some form of security, data security, close to HIPAA, if not HIPAA. And also our data is always encrypted at rest and in transit.
Wonderful. And then let's see if we can take one more question. Okay, if the patient still needs to go to another site for diagnostic tests and pharmacy, then what is the point of teleconsultation at one site not having these facilities?
Yeah, so and then this may be the case in some areas, and what it means is that we need to invest in infrastructure before we actually provide a service that depends on that infrastructure, right? So that is very important. So that should become part of our intervention, that if there is no pharmacy in a village, then we need to focus, we should make sure that that becomes part of our telemedicine initiative, that there is a pharmacy in that village, or there is a diagnostic facility close by where we can refer patients to. So that is important. So I think it is about thinking about how to design this program and what makes sense in your specific geography.
Great. One last question. We still have a minute. This question actually is quite important. I appreciated your emphasis on making the end user a priority when you are developing digital solutions, because when you talk about utilization, high utilization, and sustaining that utilization, this becomes very important. And oftentimes, sometimes that's at the bottom of the list, which is why we see an uptake in app utilization, but then you see a rapid decline as time goes on. So this particular attendee is asking, what are available resources for staff team training on digital health tools or services that are offered by them at remote primary care units? And also, how do they maintain patient history? So how do you ensure that your clinicians and end users are not only utilizing it initially, but maintaining that utilization so you get the outcomes that you were looking for?
Yeah, a very good question. So in terms of history and then all this data, clinical data, that is stored within this application in a secure environment, so that whenever I go back for a teleconsultation, and if Michele is my doctor, Michele can open her version of application and can actually see my medical history, my diagnostic test that I was advised I perform. So all that history is part of this this application, so that it means that patient will carry with him or her her personal health record, and it is all encrypted. So if somebody loses phone, we can wipe this data off, and it is encrypted all the time, so nobody can have access to that. And then again, there is some biometric security features that we are about to implement to protect from fraud for insurance companies. So yeah, I think there is a full a range of services that is available within the application, and as it should be, to make sure that we have a unique patient experience for patient without leaving his home or her home.
Right. So thank you. I think we will end it here. I will say, I want to thank Saleem Sayani again for a very informative session. We will actually have this presentation available on the ISfTEH YouTube channel. So there's so much information in there. I'm sure there are many people who would like to actually review it again and take some of those pearls for them to utilize in their respective countries and locations. Additionally, if you are interested in joining the ISfTEH, we do have the link also in the chat. And lastly, the study that you published, is there a way, I'd like to make that available too. I think that's a great resource for those that are looking to approach stakeholders about the success of the use of digital health and how it can be a cost savings measure. I mean, I thought that was a great resource there. So if there's a way we can share that with our attendees or potentially publish it on the ISfTEH website or somehow make that accessible, because I think that's a great resource. So again, thank you. Thank you.
Absolutely. I'll be happy to share that with you, Michele.
Okay, thank you.